Julius, before I ask a lot of the questions about TACE and how that goes to immunotherapy, we just take a minute and explain TACE and how you do the procedure and just kind of lay that out for us. Just a little gearhead talk.
Well, TACE, transarterial chemoembolization, is actually a very old procedure. It's been designed in Japan and then basically tested in patients mostly with what we today would describe as intermediate stage disease over the course of more than 30 years, well over 30 years actually now. And the initial protocols have been done with Hepatol, which is basically an ethiodized oil, which functions as some people call it a triple threat drug carrier, embolic agent, as well as imaging biomarker. And, that mixture, that is usually mixed in a emulsion with historically 3 drugs have been used. And this is usually doxorubicin, cisplatin, and mitomycin. Cisplatin was gone for a little while in powder form from the market, and a lot of people have used 1 or 2 drugs. Standardization of the chemoembolic mix was a problem, but I think it was addressed fairly well over the past 15 to 20 years. And I think when we do conventional chemoembolization or chemoembolization with Hepatol, we do it in a fairly standardized fashion, and then after the administration of the mix, we close the back door of the feeding artery usually with particulate embolics or gel foam. It has been demonstrated that particles are better and produce more durable responses than gel foam, which is a temporary embolic. And then, of course, there has been interest in more, some people say, reproducible form of TACE, and that was the drug-eluting beads TACE, which was introduced about 15 years ago and tested predominantly to avoid systemic spread of the chemotherapy that is being introduced, and also limit the side effects and be in a more targeted fashion. And while it has been demonstrated that it's able to reduce the sort of systemic side effects and confine the chemotherapy more to the liver and to the targets, the real outcome metrics, sort of the overall survival, tumor response rates, really have not been much different from conventional chemoembolization. And because the majority of the world from all intraarterial therapies is still using chemoembolization, it has been also the therapy of choice for most of the randomized controlled trials and high-level data. It is still the only high-level intraarterial therapy with level 1A evidence in HCC, and has been that for a while. Predominantly, I think, driven by Asia and the availability of the therapy across the board. That's what I will say about CTACE as a brief introduction, I guess, or CTACE and DEBTACE.
Can I just dig in a little bit, though? In your practice, are you using DEBs or Hepatol?
Except for the VA, where Hepatol is a non-formulary, we're using almost exclusively Hepatol in our institution.
What's your drug cocktail?
Cisplatin has been really irregularly available, so we're using mostly a double drug cocktail. Unfortunately, some of my colleagues prefer to change it from time to time. Some people had mixed it, with beads when they administered the Hepatol. In my personal experience and the way how I do it, particularly because we like standardization, I feel that a standardized approach, highly standardized way how you mix it, what you use, what kind of drugs you use is extremely important. And because doxorubicin is the one thing that is always available, I mostly use a single drug cocktail with Hepatol. Other people will say, why not using 2 or 3? It's just because the remainder of the drugs are not consistently available. And I believe that unless you do something the same way all over again, it's probably your results are not really sustainably comparable. And I would say, you have to have a rules-based practice, I would say.